Good morning, everyone. My name is Monica Quinn, and I am the Director of Pharmacy Operations at West Cancer Center. Thank you for joining the 2025 West Oncology APP Conference today. And I'll be providing an update on solid tumor therapies that were approved between October of 2024 and September of 2025. In this talk, we will not only review what was approved, but also how these agents are used, their pivotal clinical trial data, their key safety issues, and practical considerations for advanced practitioners. So let's jump right in. Here's what we're going to cover over the next 30 minutes. First, I will highlight the major new drug approvals in solid tumor organized by drug class. We'll talk about monoclonal antibodies, kinase inhibitors, bispecific antibodies, and antibody drug conjugates. For each agent, I'll briefly explain its mechanism of action and the key clinical trial results so you understand why these drugs work and what outcomes to expect. We will review the most important safety signals, dose modifications, and administration tips you can use in your daily practice. So let's start with the monoclonal antibodies. First is zolbetuximab. It is a first-in-class Claudin 18.2 directed monoclonal antibody. It is approved in combination with fluoropyrimidine and platinum-containing chemotherapy for the first-line treatment of adults with locally advanced, unresectable, or metastatic HER2-negative gastric or gastroesophageal junction adenocarcinoma, whose tumors are Claudin 18.2 positive. In the Spotlight trial using modified FOLFOX6 and the GLOW trial using CAPOX, zolbetuximab plus chemotherapy significantly improves progression-free survival compared to chemotherapy alone. Median progression-free survival was 10.6 months versus 8.7 months in Spotlight and 8.2 months versus 6.8 months in GLOW. This drug carries high rates of nausea and vomiting, fatigue, decreased appetite, neuropathy, and abdominal pain, with serious adverse reactions in 45% of patients and fatal reactions in 5%. 20% discontinued therapy and 75% required dose interruptions. The recommended dose is 800 milligrams per meter squared initially, followed by 600 milligrams per meter squared once every 3 weeks, or 400 milligrams per meter squared once every 2 weeks in combination with modified FOLFOX6 or CAPOX. Going back to zolbetuximab, aggressive antiemetic prophylaxis is crucial. We need hypersensitivity kits at chairside, and nurses should be prepared for high rates of dose interruption. The second monoclonal antibody is colebelimab. It is a PD-L1 blocking antibody approved for adults with metastatic or locally advanced cutaneous squamous cell carcinoma who are not candidates for curative surgery or radiation. In the CK301-101 study, the overall response rate was 37% in metastatic disease and 15% in locally advanced disease. Median duration of response was not reached for the metastatic group and 1.7 months for locally advanced disease. Common adverse events include fatigue, musculoskeletal pain, rash, diarrhea, and hypothyroidism, with serious adverse events such as sepsis and pneumonia. 8% of patients permanently discontinued, and this agent shares the same immune-related toxicity as other checkpoint inhibitors. Practitioners should monitor thyroid labs and escalate steroids early for severe immune adverse reactions. The recommended dose is 1,200 milligrams administered via IV infusion over 60 minutes every 3 weeks. Next, we'll discuss the kinase inhibitors. The first is ensartinib, and it is an ALK inhibitor indicated for the treatment of naive, ALK-positive, locally advanced, or metastatic non-small cell lung cancer. In the EXALT-3 study, the median progression-free survival was 25.8 months compared to 12.7 months with crizotinib. The most common adverse events were rash, musculoskeletal pain, edema, vomiting, pneumonia, and hemorrhage. 12% of patients permanently discontinued therapy, with 41% requiring interruptions. We should monitor hepatic function and rash and counsel patients to avoid strong CYP3A inhibitors or inducers. The recommended dose of ensartinib is 225 milligrams orally once a day. Avometinib plus defactinib is a dual MEK and FACT inhibitor regimen approved for KRAS mutated recurrent low grade serous ovarian cancer after prior therapy. In the RAMP 201 trial, the overall response rate was 44%, with a duration of response of 3.3 months. The most common adverse events included nausea, rash, musculoskeletal pain, visual impairment, and stomatitis. There was an 84% interruption rate and a 44% dose reduction rate, with 3.6% fatal adverse reactions from intestinal obstruction and perforation. The recommended dose is avometinib 3.2 milligrams administered orally twice weekly on days 1 and 4 for the first 3 weeks of each 4-week cycle, along with defactinib 200 milligrams administered orally twice daily for the first 3 weeks of each 4-week cycle. We must pay close attention to drug interactions with strong or moderate CYP3A inhibitors and inducers and gastric acid reducing agents. Also, patients should be counseled about ocular symptoms and have regular laboratory monitoring. Next is trilaciclib. It is a ROS1 inhibitor indicated for ROS1 positive non-small cell lung cancer. In the TRUST studies, it demonstrated significant activity in the central nervous system. The objective response rate was 90% and 85% in the TRUST 1 and TRUST 2 studies, respectively, for TKI naive patients, and 52% and 62% in TKI pretreated patients, with a median duration of response of 13.2 months in the TRUST 1 study. Common adverse events were diarrhea, nausea, dizziness, and hepatotoxicity, with a 5% fatal adverse events rate. The recommended dose is 600 milligrams orally once daily. Patients must take it on an empty stomach with no food for 2 hours before and after, and avoid grapefruits while on therapy. Baseline echocardiograms, uric acid, and electrolytes should be obtained, and patients should be counseled on sun protection during treatment and for 5 days after discontinuation. Next is zongertinib. It is a HER2 selective tyrosine kinase inhibitor for adults with unresectable or metastatic non-small cell lung cancer whose tumors have HER2 tyrosine kinase dominant activating mutation and who have received prior chemotherapy. In the BEAMION Lung 1 trial, the objective response rate was 75%, with a short duration of response. Serious adverse reactions occurred in 34% of patients, most commonly due to dyspnea, pulmonary embolism, hepatotoxicity, and pneumonia. Dosing is weight-based at 120 milligrams for patients under 90 kilograms and 180 milligrams for doses above 90 kilograms. Patients should be monitored for cardiac symptoms, particularly cardiac ejection fraction, and then anticipated hepatotoxicity for these patients. The next drug is sunverdinib. It is an EGFR exon 20 insertion inhibitor approved for adults with locally advanced or metastatic non-small cell lung cancer whose disease has progressed on or after platinum-based chemotherapy. In the Wukong 1B trial, the overall response rate was 46%, with a median duration of response of 11.1 months. Serious adverse reactions occurred in 41% of patients, mainly due to pneumonia, dyspnea, device-related infection, and rash. Dose interruptions occurred in 48% of patients, and these were due to vomiting, pneumonia, and rash. So manage patients' rash and diarrhea proactively as there is a high dose interruption rate. The recommended dose is 200 milligrams orally once daily with food. We want to also monitor for drug interactions with strong CYP3A inhibitors and inducers, as well as oral hormonal contraceptives. The next drug is inavosilib, and it is a PI3 kinase inhibitor approved in combination with palbociclib and fulvestrant for endocrine-resistant PIK3CA mutated hormone receptor positive and HER2 negative breast cancer after adjuvant endocrine therapy. In the Innova 120 study, median progression-free survival was 15 months versus placebo. Dose interruptions occurred in 69% of patients. 24% of patients experienced serious adverse reactions, and these were most commonly due to anemia, diarrhea, and urinary tract infection. Hyperglycemia is common with this drug, so baseline fasting, glucose, and A1C should be checked. The recommended dose is 9 milligrams once daily, orally, and dose reduction should be performed for stomatitis and monitor for neutropenia with palbociclib. Okay. Next, we'll discuss the bispecific antibodies. And the first one is zanidatamab. It is a HER2-directed bispecific antibody approved for adults with previously treated unresectable or metastatic HER2-positive biliary cancer. In the Horizon BTC-01 study, the objective response rate was 52% with a median duration of response of 14.9 months. The most common adverse reactions included diarrhea, infusion-related reactions, abdominal pain, and fatigue. Serious events occurred in 53% of patients, and this drug has a box warning for embryo-fetal toxicity. The recommended dose is 20 milligrams per kilogram, administered as an IV infusion once every 2 weeks. Infusion times are initially 120 to 150 minutes for the first 2 infusions, but can be shortened to 60 minutes once tolerated. The next drug is zonacatuzumab. It is a bispecific HER2 and HER3 directed antibody for advanced non-small cell lung cancer and pancreatic adenocarcinoma harboring an NRG1 gene fusion. In the energy study, the objective response rate was 33% in non-small cell lung cancer and 40% in the pancreatic cancer, with a median duration of response of 7.4 and 3.7 months, respectively. There was a 23 to 25% of the patient population experienced severe adverse reactions due to pneumonia, dyspnea, and fatigue. Dose interruptions occurred in 29 to 23% of patients, and these were mainly due to infusion-related reactions. The recommended dosage is 750 milligrams administered via an IV infusion over 4 hours every 2 weeks. Patients should be monitored for infusion reactions as well as counseled on early respiratory symptoms. Next, we'll discuss the antibody drug conjugates. The first one is datopotamab deruxtecan. It is a TROP2 directed antibody conjugate to a topoisomerase inhibitor for hormone receptor positive, HER2 negative, unresectable, or metastatic breast cancer after endocrine therapy and chemotherapy. I would also like to make a note that datopotamab deruxtecan was recently approved for locally advanced or metastatic EGFR mutated non-small cell lung cancer. But for the purpose of this presentation, we'll review the results of the Troponin Breast-01 trial. In the Troponin Breast-01 trial, median progression-free survival was 6.9 months and compared with 4.9 months for chemotherapy, and median overall survival was 18.6 months versus 18.3 months. Stomatitis, ocular adverse reactions, and interstitial lung disease are notable adverse events. Although the fatal interstitial lung disease rate was low at 0.3%, we should obtain baseline pulmonary status and evaluate new cough or dyspnea promptly. The recommended dose is 6 milligrams per kilogram, up to a maximum dose of 540 milligrams. And this is administered via IV infusion every 3 weeks. Infusion time is 90 minutes for the first dose and 30 minutes for subsequent doses, as long as the patient tolerates the first dose. Patients should be instructed to hold ice chips or ice water in their mouth throughout the infusion and use steroid-containing mouthwash for prophylaxis and treatment of stomatitis. Next, we have telisotuzumab vedotin. It is a microtubule inhibitor conjugate approved for treatment of adult patients with locally advanced or metastatic non-squamous, non-small cell lung cancer with high c-Met protein overexpression. In the Lumosity trial study, the overall response rate was 35%, with a median duration of response of 7.2 months. Peripheral neuropathy, interstitial lung disease, pneumonia, and fatigue are common. There was a 5% fatal adverse event rate and 30% permanent discontinuation rate. Monitor for neuropathy closely and dose reduction at early signs. Infuse 1.9 milligrams per kilogram every 2 weeks and pre-medicate for infusion reactions. And in closing, the past 12 months have brought an unprecedented number of novel mechanisms in solid tumor, from Claudin 18.2 monoclonal antibodies to bispecific antibodies and next generation kinase inhibitors, as well as antibody drug conjugates. As advanced practitioners and pharmacists, our roles is to ensure testing, administrating, monitoring, and patient education are optimized so that patients can receive these therapies safely and effectively. Thank you all for your attention, and thank you for the work that you do every day. I would be happy to take any questions at this time.